What do they say? Train PHC personnel, integrate mental health with primary health care. Disease Control in Developing Countries project. This is Steve Hyman. He is the main author, but this is a big project, funded also partly from the Bill Gates and Melinda Gates Foundation. Then Lancet series, one of its very distinguished authors is sitting on the dais here. The Lancet series, a series of papers. They have looked at extensively all that is available, the evidence, hard literature, grey literature everywhere. And what did they say? Mental health should be recognized as an integral component of primary and secondary general health care, particularly in low and middle income countries. So we have to now do this. Is there any other wisdom for taking mental health and making care accessible to remote areas? I don't know if there is any other method. WHO and WONCA has recently come out. This is I think 2008 or 2009. WONCA is the World Organization of Family Doctors, who say that this is a very good report, again accessible from the WHO's website. Lot of information, integrating mental health into primary care, a global perspective. This is a good book, but why I liked it particularly, it reaffirms the urgent importance and advantage of integrating mental health into primary care systems around the world. The report shows that integration is achievable in all countries. You don't have to read this. She said that in Nilgiris it's possible. If it's possible so close by without much effort, then it should be possible everywhere. And this book gives case studies of best practices, 10 best practices from all over the world. And you find the Thiruvananthapuram district of Kerala state described with all the data. So read this and find out for yourself, is it an abject failure or is it a success or whatever. Data is available, evidence is available. The latest program of the World Health Organization, new program launched by the WHO for low and middle income countries with the objective to scale up care for mental, neurological and substance abuse disorders. It's called the MH-GAP, Mental Health Gap Action Program, again guided by our own Dr. Shekhar Saxena, who is now the Director for the Division of Mental Health of World Health Organization. What about India? The Dr. Kapoor's article was referred to. There's also an article by Dr. Murthy. So you have to balance both the views from the book by Agarwal. This is from the editorial in the Indian Journal of Psychiatry, which says gradual implementation of district mental health program in a phased manner with support of adequate managerial, financial input is a need of the day. So, but there are other problems. When hardcore researchers look at things, what is the evidence, where is the evidence? What I presented till now is one kind of evidence. When academicians working in universities, professors, etc., when they look at it, they look at things much more critically and much more with a sharper, high focus microscope. This is from a famous paper in the American Journal of Psychiatry. Most training programs consist of short courses focusing on diagnosis and pharmacological management without much emphasis on skill acquisition and application in clinical settings. You don't have to read this paper. I think this is the gist of what many people say. Giving medicine is not the total care. Total care means much more. And these people say that is what needs to be done. But unfortunately, in most mental health programs, this is what happens. While mental health training programs for primary care personnel may bring about improvements in mental health knowledge and attitudes, there is only little evidence of changes in actual practices of health workers. The point is that they need continuous on-the-job training, supervision, and that is very often in most programs not given. They are called, given an excellent program, they are followed up for 1 or 2 months, good results, but it's gradually, comes down because continuous support, supervision and monitoring is not there. Although diagnostic sensitivity of trained workers increases, there is inadequate evidence that such improvement results in better outcome for patients. This is something which requires to be seen in greater detail. Similarly, while there is evidence for excellent management of epilepsy and those kinds of conditions, about other conditions, there is little evidence. It's not just in India, from our district mental health program. This is an article from the Harvard the Review of Psychiatry, which has looked at common mental disorders, the larger proportion of people who present in primary care settings all over the world, in rich countries as well as poor countries. Common mental disorders in primary healthcare, current practice. This particular paper is about low-income countries. And what does the review say? Much remains unknown, undocumented, unshared. In other words, we don't even know whether going to a temple and receiving a counseling or going to Tirupati and praying, is that enough for some kinds of conditions? I mean, you are including common mental disorders. I mean, now the extent of common mental disorders is increasing. So much so the big debate for the DSM-5 is, are you making every other normal person also mentally ill? So the issue, the point I'm making is, of course we know about serious mental disorders which require a certain kind of management. But when you come to common mental disorders, we need to have better clarity as to what we are talking about. This is Dr. Goyal, who used to work with the Government of India's mental health program. He says that even adequately funded programs sometimes fail due to factors such as top-down approach to planning, divorce from ground realities, poor governance, managerial incompetence, unrealistic expectations from low-paid and poorly motivated primary care staff. Large number of, in Tamil Nadu, the primary care staff may be much better motivated. Otherwise, the health secretary can't say that it's such a big success. But maybe in Jharkhand or maybe in Chhattisgarh, they are poorly paid, low paid and poorly motivated. How much can you expect from them? Now, future recommendation, I must also quickly tell you the changing focus. I will not take much time because it may not be very relevant. What I wanted to say was that we are integrating mental health with primary care. We have a concept, at least when I started working, I had a concept of what that primary care was. That was from Alma Ata, the comprehensive universal provision of primary health care. The slogan for all the countries in the world was health for all by 2008. But what happened subsequently? From Alma Ata to Millennium Development Goals, we have gone a long way. We made comprehensive primary care, selective primary health care. You immunize on polio and prevent polio, that is fine. Or you have a TB program, that's fine. The comprehensive primary health care, well, for a variety of reasons, because they were vested interests. I will not go again into the details of that. Investing in health. World Health Organization, UNICEF, etc. were moved out, and World Bank and other funding organizations came in. Their concepts were different. They were result oriented. But in the process, many public health people wonder whether they have, in some sense, done some harm to the primary healthcare movement. But then they realized that investing in health, just by investing money, things will not change. And in 2000, the WHO, UN came with the United Nations Millennium Declaration. Now we have a set of goals. By 2015 we have to achieve that. But the good thing is that in the last few years there has been a resurgence on PHC, and the whole world is looking at primary health care as the primary mode for delivering not just mental health but all forms of health care. And in India, we have our own form of this resurgence in primary health care, and that is in the National Rural Health Mission, which arguably is performing better than the routine primary care. I will not again go into the details. I will now quickly skip all these slides because this is about the history of how we moved from Alma Ata to the Millennium Development Goals. Investing in health, Commission on Macroeconomics and Health. The Millennium Development Goals also, in the Midway Review in 2007, they said that the most important variable was the health systems. Critical health system related challenges were there to achieve. I mean, you can't just pour money into a PHC or in a place and expect everything to be all. You have to have a system. So, need for substantial strengthening of the health system. If mental health and primary health care has not worked, part of the problem is that we need to strengthen the basic health system itself. Do we go for vertical disease or condition-specific programs or horizontal programs? The final answer is still, there are some people who say that we must have specialist trained mental health workers in every PHC. Don't know, that is still a debate. The United Nations Framework for Development does not include chronic non-communicable diseases. United Nations is still fighting battle on children dying of malaria and dysentery in Africa and all that. So non-communicable diseases and mental illness has not yet come into the UN's plan of action. After observance of the 30th anniversary, there is a resurgence. NRHM, you know about it. One of the recommendations that I am going to make is that NMHP should be linked to NRHM, and that's why I am talking about this. Induction of management of financial personnel into the district health system. There is a paper called MINT, the Madras edition today. There is a nice article on the NRHM and the kind of managerial requirements. It is written by the Joint Secretary Health. It's very interesting and instructive. The point is that even health systems to function better, require management input. Many doctors or nurses or health workers may not have those kinds of skills. And many of the problems of the district mental health program, when you carefully look through the ICMR report, you find that those managerial inputs are not there. The NRHM has a village level worker called ASHA, the accredited social health system, and this Kerala program in Karnataka. Some of the improvements have occurred because the DMHP has been linked to the NRHM program. Future of DMHP. Plans and proposals are most likely to lead to action only if they are accompanied by detailed specification and clear instructions of what needs to be done. In other words, what I'm saying is that is lacking in the current program. In fact, in my study, what I find is that what was done till 1996, although there has been some kind of a strategization in terms of the technical components of the district mental health program, nothing has been done. I give you an example. The pay scale is the same, whereas the government of India has had 2 pay commissions. I mean, where will you get a psychiatrist at 10,000 or 15,000, where today the government of India rate is maybe 50,000 to 60,000. These are just snapshot examples of why in many places the DMHP is not working very well. What the barriers are likely to be and the implementing ways should be shown. One size does not fit all. I mean, we have heard from a lot of people already that South people are more aware, people are coming earlier. What is good for Tamil Nadu may not be good for Chhattisgarh. Local issues should be identified. Innovation, partnerships and collaboration very important. The non-governmental sector has only looked at the DMHP mainly to look at it critically and criticize it. They have not taken active role. They have not taken, let's say, none of the NGOs have come forward saying, we'll take this district, you give us the money and we'll implement it. Maybe you have, and you should talk to your health secretary whom you already know very well, and you might be given that chance. Better coordination at all levels, real leadership at the most senior, professional, political and bureaucratic levels. Carer and user organization involvement. I mean, lot of inputs that for me it has been very instructive listening to the carers